have our team from Dell Children's in Austin here. So Dr. Harrod received her MD at the University of Texas Medical School in Houston. She received her PhD at the University of Texas Graduate School of Biomedical Sciences in association with the MD Anderson Cancer Center. And then she completed her residency at the Children's Hospital of Austin and her fellowship at St. Jude's Children's Research Hospital. She is currently the Pediatric Neuro Oncologist at Dell Children's in Austin in association with the University of Texas Dell Medical School. Dr. Harrod will be presenting on various tumors, brain tumors in NF1. So Dr. Harrod, thank you so much for being with us this morning. And we were able to share, oh, there it is, you got it. It's always good when technology works for us, right?
Try and get the screen here, put on a presentation mode. There we go. Are we good?
We're good.
All right, fantastic. Well, I would like to thank the organizers for inviting me to speak today. And thank you, Dr. Moodley, for covering the neurological part of neurofibromatosis. My talk is going to focus primarily on brain tumors, specifically associated with neurofibromatosis today, and there'll be some overlap, of course, with the talk that Dr. Moodley just gave, and also just a little bit from the previous presenters, but I'll try and go quickly through those sections since we've already been seeing much of that information. So Dr. Moodley, thank you so much for going over headaches, a little bit of hydrocephalus, some moya and stroke, and especially neurocognitive concerns, which are a huge concern for patients and families affected by the neurofibromatosis disease. My talk is going to focus on the tumors associated with neurofibromatosis. And so we're going to talk specifically to what evaluations are needed for neurofibromatosis patients. One of the main questions I get from pediatricians and families is, when do I get the MRI? I need the MRI. When do I get the MRI, Dr. Harrod? And so we'll talk a little bit about when to look at the brain, what the imaging recommendations would be, and the guidelines put out by the Neurofibromatosis Society and Foundation. And then I will break down the tumors of the brain with a high percentage of our time today talking about optic pathway tumors, as well as low-grade gliomas. And I put brainstem gliomas in parentheses because most of these are located in the brainstem in NF populations. I will very briefly talk about high-grade gliomas and intraspinal tumors, really just a slide or two on each, because those are primarily adult diagnoses. And as a pediatric neuro-oncologist, I don't see those as commonly, but they do happen in NF, and I wanted to touch on them. I will not be spending much time on MPNST, but you will see a slide or two on that and how it might impact the brain or the spine. And then we'll wrap up with treatment that'll be embedded a little bit in the tumors themselves, but an overview at the end of treatment and outcomes of these tumors in the NF population. So what do we do and when do we do evaluations of the brain in neurofibromatosis? What is our routine screening? We do have routine screening, but it's with physical evaluations, including a physical exam by a neurofibromatosis specialist and an ophthalmologist who understands pediatric patients. The physical evaluation is a primary and key component to our evaluations in these patients. And it's very routine and scheduled. It needs to happen at least every 12 months, and sometimes even as often as every 6 months in an at-risk patient. We also have routine screening with neuropsychological evaluations, looking for some of those neurocognitive effects that Dr. Moodley touched on earlier. And those need to also happen on a very routine basis. Is a radiographic evaluation, aka an MRI scan or other imaging of the brain, a routine evaluation? I would actually argue, and the neurofibromatosis guidelines show that this is not part of routine screening. What it is it depends on what you find with your physical evaluations and your ophthalmological evaluations and your neuropsychological evaluations. Then you can look into is this patient in need of an MRI to more fully understand what their physical exam is telling us. And the reason for this is you kind of have to be careful what you look for. Dr. Moodley touched on UBOs and FACEs, or the focal areas of signal intensity, they're sometimes referred as, in his talk. And I'll go over those in just one or two slides here. But I think it's important to remember these are things we see. There were even some questions on them with the previous talk. We see these, but they actually, we're not sure if they're connected with any clinical finding. And if they are, it doesn't change what we do about that clinical finding. So any abnormality you find tends to lead to more scans, which leads to more anesthesia, because most of these patients are of an age that they can't lie still, which leads to more contrast administration, because unlike peripheral neurofibromas in the morning talks, those MRI scans don't necessarily require contrast, but brain tumors and evaluations for brain tumors do require contrast. And none of these are without toxicity. So a brief picture, Dr. Moodley had better examples than I do on the UBOs, but this is really considered not pathological. It is diagnosed. That was one of the questions that came up on the chat box. It's diagnosed basically by an MRI scan. There are no other really strongly connected clinical findings to UBOs. There is some thought, and there are some studies that it may be connected with a cognitive impairment, especially UBOs that are found in the thalamic region, but this hasn't played out to be true and reproducible in a wider selection of tests and studies done. Having said that, most patients, if you scan them, you will find bright spots. I'm not sure if you can see my cursor, but just a signal abnormality, a little bit kind of looks like clouds in what should be a darker part of the brain. These white spots are usually found in the majority of patients with NF under 10 years of age. They grow in size up to about 10 years of age. They are not associated with any inflammatory components. And after 10 years of age, you would actually expect them to either be stable or even decrease and sometimes even disappear over time. If they continue to grow after 10 years of age, become more prominent, then we actually consider if that might have actually been a very early onset of a glioma or some other finding in the older age group. So when do we do an MRI of the brain in NF patients? Dr. Moodley went over this, so I won't belabor the points too much. But the number one point that we see in the young pediatric would be a visual change by ophthalmology evaluation or some other type of neurological change in the patient based on their physical exam and their comprehensive annual screening. The problem with brain MRIs, pros and cons, as with anything. What if you have a negative MRI? I was worried about something, the ophthalmologist, my child didn't cooperate, I didn't get a good exam, we did an MRI, it's negative. That's great, except that's really just a moment in time and it doesn't predict the future. So it doesn't really tell us what might happen in the future, it just tells us that there's nothing happening here, which can be extremely reassuring, but it doesn't change the need for routine screening. You still need to go to the doctor every year, you still need to go back to the ophthalmologist. And you need to have those routine evaluations done on a physical exam basis. There can be positive findings. I see something, we were worried, we had a headache, we did a scan, and I see something now that is concerning. That doesn't actually mean that we would treat this though. Treatment being some sort of medical or chemotherapy intervention. Oftentimes we see something and we're like, okay, let's watch it. If you don't have an actively changing finding or a decrease in neurological function, a change in vision or a change in precocious puberty or some other finding, then we don't always bring on the very toxic effects of chemotherapy. It almost always, though, leads to more scans, which can lead to more anesthesia, more contrast administration, more anxiety. And that's not just anxiety for the patient with having the blood stick or the IV start, the blood draw, having to go to sleep, being in a hospital environment. That's very unsettling for an 8-year-old or a 5-year-old, but there's anxiety for the parents. You know, my child is screaming, my child's crying. what is the scan? When do I get the scan results? There's a lot of anxiety, and this does negatively impact quality of life. Oncologic complications of the brain in NF. Let's focus now on the tumors. We've kind of gone over when we would want to do the MRI scan, the pros and cons of doing MRI scans. But the tumors themselves, optic pathway tumors will be our first topic of discussion, and then we'll get into the later list there. So 15 to 20% of patients with neurofibromatosis type 1 will develop a CNS tumor. Most commonly, it's optic pathway gliomas. So they get lumped together as one large category for the most part. Within optic pathway gliomas, 30 to 50% will be symptomatic. Well, what does that mean? That means 50% of the time, this patient is not going to have a vision change, is not going to have any sort of pain at the eye or any or other deformation at the eye or the visual symptom. However, a third do require some sort of treatment or intervention. One of the difficulties with optic pathway gliomas, Dr. Moodley put on his very comprehensive timeline, these most commonly occur prior to 6 years old. And so it's very difficult to get visual assessment. I don't even like going and looking through those things at the eye doctor. How do you get a 4-year-old to do that? Very difficult. These gliomas can develop anywhere in the optic pathway. It's not just the eye, but it's the entire visual pathway to the back of the brain. And depending on where the lesion occurs, that determines your symptoms of where visual loss may happen. And I've got a cartoon in a slide or two to go over that. But just to kind of reinforce the point, most of these present at very young ages. Ophthalmology exams are very hard, but they're not impossible if you have a pediatric ophthalmologist knowledgeable about what they're looking for and knowledgeable about what the neurofibromatosis population is. This is not going to be a blow-off evaluation of a 3-year-old. This is a 3-year-old with neurofibromatosis, needs to be seen by a subspecialist that understands neurofibromatosis and understands kids and how to look and get kids to cooperate as best as possible with these evaluations. The reason for that is the next line down. MRI screening is not recommended routinely. This was actually published in the 2019 Health Supervision Guidelines for Neurofibromatosis and the Optic Pathway Glioma Task Force. The risks are what we've talked about before. The benefits are early detection, but not necessarily intervention unless there's a vision loss or a change in size. So the ophthalmology evaluations are really key to catching cases of visual loss. And then again, as we've mentioned, most of these patients don't actually have vision change. So optic pathway gliomas, chemotherapy can help stop further vision loss. So if you see a loss of vision, chemotherapy can kind of stop it in its tracks most of the time, but it doesn't always improve or regain the vision that you have lost, although it can happen sometimes. 30% you might have an improvement of vision. Risk factors for children who may have vision loss, the younger the age of diagnosis tends to have an increased chance of vision loss. And in the extremely rare case of an optic pathway glioma occurring after 10 years of age, there can also be an increased risk for vision loss. There's also optic tract or radiation involvement. When we look at my cartoon in just a minute on the next slide, the optic tracts and radiation are when the tumors are in the back part of the brain, not right next to the eye. And then females tend to have a higher risk for vision loss that we don't fully understand over males. Here's the cartoon I was mentioning. And what you can see here is we have your 2 eyeballs, and it's color coded here where we have some blue pathways you can follow that go to this intersection, just like a highway exchange. This is called the optic chiasm, where fibers cross over and then they collect and they go to the back of the visual cortex, which is the very back part of the brain. So anywhere in this entire pathway would be considered an optic pathway glioma. If the tumor occurs here near the eye or in what we call the optic nerve, the connection to this major crossover or bridge at the chiasm, then we would usually expect unilateral or one-sided vision loss. If the pathway or the tumor occurs at the chiasm or involves the chiasm and further back in what these are the radiations of the optic pathway, those would actually result in a bilateral or both sides of the eyes, both eyes being involved in visual loss. And that has to do with the way the fibers actually cross over and speak to each other as they're processed through your brain system. This is an actual MRI scan of an optic pathway glioma. On the left panel, you can see that there are your two eyes and your nose. And it's important to remember, there's a little ear and another little ear over here. If you are looking at a brain MRI, it's very similar to looking in the mirror. So the left side of the picture is the right side of the patient. The right side of the picture is the left side of the patient. In this case, this is actually a chiasmic tumor, or in the middle portion here, there's a thickening of the optic chiasm. This is an optic nerve coming back, some optic nerves coming back, and there's a brightness and a thickness to this chiasm. And so in this particular patient, we would expect that if there's vision loss, it might be bilateral. And this area of the brain is also connected closely to the pituitary, and there may be some issues with precocious puberty. And so these types of tumors are watched very closely for those visual changes and hormonal changes. On the right panel, this is one where you can actually see, here is your eye. And again, this is the left side of the face. So this is the left eye. This is an optic nerve glioma, which is involving the optic nerve directly behind the eye to the chiasm. And it's very thickened and full, similar to earlier this morning, we talked about a bag of worms. This is a single worm that is fat and kind of going back towards the center part of the brain, the chiasm. On the right side of the patient, the left side of the picture, there's actually some thickening here as well on the right optic nerve, but not nearly as much as what you see on the left side. So there may be bilateral optic nerve, or there's bilateral optic nerve involvement, but the visual changes we might expect more on the left side than the right side. So what do we do and when do we treat? I already kind of alluded to, I have to have usually a vision loss or a change in size of these tumors to actually move forward with a treatment intervention. These treatments are not without side effects and toxicities. And so we want to be sure that we treat appropriately and not in what we would call an asymptomatic or a patient without any symptoms. When we used to biopsy some of these tumors, they are considered pilocytic astrocytomas. This is a very low grade WHO grade 1 tumor, very slow growing, and with a very low propensity for metastasis or moving to different parts of the brain. When we treat these slow growing tumors, we do use chemotherapy in neurofibromatosis and other patients. Typically, what I would call our backbone or historic treatment has been something called carboplatin and vincristine. Those are two chemotherapy agents. They come with your traditional chemotherapy side effects that you think of, like nausea and vomiting and things like that, but they're honestly fairly well tolerated in the chemotherapy world. Something specific to them, or hearing loss can be associated with carboplatin, and peripheral neuropathies, which is pain in your hands and feet, or some change in sensation and walking ability. So again, they're not without toxicity, but we use them and they are, generally speaking, well tolerated. Vinblastine is listed here as a very common substitute, and I put other here because, as most of the talks this morning mentioned, there are now MEK inhibitors and other treatments that we can use, and we'll talk about those in another slide. Treatment with these chemotherapy agents, again, this is not only are the drugs with toxicity, but the actual administration of the drugs comes with anxiety as well, and some extra interventions that are needed. For example, these medicines are only IV, and so it does require weekly IV infusions. It's very hard to get a little 2-year-old or a 4-year-old or a 6-year-old to stay still and have an IV placed. And plus, their little veins are very small. So we usually place what's called a central line or a portacatheter, and that is for ease of administration of the drugs, as well as blood work that we need to do to monitor for toxicities and side effects. And then, of course, we continue with MRI scans that monitor for our disease response every 3 months. New drug therapies, I'll go over in mild detail because it's already been covered very well earlier this morning. They have been approved for plexiform neurofibromas. That was mentioned earlier in April 2020, and it's because we saw that nice response in plexiform neurofibromas. In the world of FDA, for people that are not aware, because something is approved for a plexiform neurofibroma, it does not mean it's approved for an optic glioma or a different brain tumor or a different tumor or a different tumor. It actually has to be tested with each one of those situations. And so right now it is being tested in up to 10 different types of tumors, and that includes brain tumors in children. Other drugs that I'm not going to talk on too much, but others have already mentioned, we do have mTOR inhibitors, which can help slow growth of tumors. We can target EGFR and other types of vascular targets as well. Just to mention one of the studies, this is actually a phase 3 study, which is one of the more advanced phases of studies when we look at drugs and their treatment of different types of diseases. This is a children's oncology group study that is being used for neurofibromatosis patients that have optic pathway gliomas or other brain tumors. And what it is trialing is that historical chemotherapy I mentioned, the carboplatin and vincristine, against, in this case, selumetinib. And the patients are being randomized, so you don't get a choice as to what you get. If you get enrolled on this study, 2/3 are being randomized to the selumetinib arm, and 1/3 will get the historical control or the vincristine carboplatin. This study opened across the United States 2 years ago now, October of 2019, and it has ongoing patient enrollment. It usually takes about 5 years for us to enroll across the country to reach accrual levels and get our statistics for these types of studies. And I'm just going to show you kind of what a response might be. This is that patient with a very large left-sided optic nerve glioma and a smaller right-sided optic nerve glioma. This patient underwent treatment for the 15 months with carboplatin and vincristine, and there was a nice response here with shrinkage of the tumor, and the right side actually looks almost like a normal optic nerve. It is important to note that this patient, although we had a good treatment response on MRI scan, we did not have any improvement in vision. So just because the MRI shows that things are better does not mean that the actual patient will have a visual benefit. We did have stabilization though, and that was the goal, is to stabilize the vision where it was so we didn't continue to have further vision loss. So outcomes of optic pathway gliomas. Really, we have historical data because that research study is still ongoing. We have an event-free survival of about 70%. I think it's important to know two things here, especially for some of our audience that's not as familiar with research trials and the terminology that we use. Number one, optic pathway gliomas, of course, happen in neurofibromatosis patients, but they also happen in non-NF patients. And the statistics and the survival and the complication rate is different for non-NF patients. And NF patients typically do better than non-NF patients. So it's important if you're going to be reading and reviewing different articles or talking to different people to really know that those two populations need to be separated. Also, event-free survival is not the same as OS, or overall survival. Event-free survival means that at 5 years after the patient received treatment, how many patients had a complication of their tumor, or how many patients continued on with no events, no problems. So event-free is no problems and just cruising right along. 70% did well, cruising right along. 30% had some sort of event, either visual loss, tumor growth, or other issue. Again, these are not without their toxicities. This doesn't even go into nausea, vomiting, and the ones people think of. I'm pointing out the ones specific to vincristine and carboplatin. But 20% had side effects related to peripheral neuropathies. 10% of these patients developed a hypersensitivity to carboplatin, which is very similar to an allergic reaction to your drug and your treatment. This is, I think, an interesting statistics for everyone to be aware of, that 32% actually had a visual improvement, 40% had visual stabilization, but that leaves 28% that actually had worsening visual symptoms or vision loss, and therefore this was not an effective treatment for them. The goals of therapy are preservation of vision, not necessarily radiographic response, meaning the MRI can be the same or better or whatever. It's really, did you preserve vision? is what we're going for. So optic pathway gliomas, referring back to the current study that's ongoing. Why do we do studies? Why do we look at new drugs? Well, we want to get better. I'm not satisfied with 70%. That's just not agreeable to me. And so I want to do better with fewer toxicities. So a better overall response and fewer toxicities. The MEK inhibitors, on some levels, parents are like, this sounds awesome. It's a pill. I don't need IV infusions. I don't need an IV line, that portacatheter. I don't have to come every week. That sounds great, except in reality, this is an oral pill. To date, it's not available in another formulation. So we can't just crush it into liquid or do other things. That is coming through the pipeline. The drug companies are very aware that this is a very young group of patients that we really need another option for. But you do have to be able to swallow a pill to be able to take this as it's prescribed and in this clinical setting. It's also daily use. And so you have to remember to take a pill every day. And we as adults know that we sometimes have trouble remembering to take our medicines. How are you going to get your 6-year-old to do that? That's difficult as well, especially when you're trying to do it before school without eating and this, that, and the other. It's also 2 years of treatment instead of 12 to 15 months. So it's a longer treatment plan. And I think something that we just don't know, the study will help us understand this, but the research with Plexiform neurofibromas, some of the tumors regrew when the medication was stopped. That was presented this morning at one of the conferences. And what happens with the brain tumors? What happens with the optic nerve gliomas? Does that happen too? And we just don't know. So you have to understand that we don't have the answers to some of these things, and we'll get there someday, but it's not today. So there's an unknown component. I'm not going to go over this in a lot of detail because it's already been reviewed in much better detail and with better slides than what I have here. But the MEK inhibitor stops this cell proliferation pathway in its tracks. That's the goal. Put the stop sign in the highway. Unfortunately, there are side effects with any drug, and GI disturbance and skin toxicities are two of the most common. Something to specifically point out with MEK inhibitors, we're talking about optic pathway gliomas, and we're talking about a patient, a child, with a visual deficit, vision loss. One of the major, minor toxicity, but big on the importance list is eye toxicity. You can actually have retinal detachment with this drug. So I have a patient with vision loss, and I'm talking about using a drug that may impact the vision of whatever vision I have left. That's a hard, excuse the pun, but that's a hard pill to swallow. So now these things have been shown to be reversible in some instances. So it's just not clear cut is what I'm trying to kind of throw out there. It's not a home run. It's not, I think, the answer to everything. I think it's super exciting, and I'm hugely in favor of the study, but we have to be cautious and very comprehensive in thinking through whether this is right for each patient. We also have cardiac toxicity, which was also reviewed today, looking at heart function. All right, we've talked a lot about optic pathway gliomas. Let's spend a little bit of time on the next subject line here, the low-grade gliomas. Most commonly, low-grade gliomas in the NF population are located in the area of the brain called the brain stem. Okay, this is actually poorly studied compared to optic pathway gliomas. We do know some information, but just optic pathway gliomas are way up there on the list of neurofibromatosis studies, and these are just lower. We just don't have the same number of patients in the medical literature. These are usually very indolent, meaning they're slow growing. They don't usually cause a lot of symptoms or problems, and they're most often discovered incidentally, often because we're following for an optic pathway glioma, and then something else comes along. We're like, what's this? And we have to now follow this as well. When they've been biopsied, they are also in the pilocytic astrocytoma category, meaning that they're a low-grade tumor that's not growing fast and it's not having a high propensity to change. And the average age, in some studies, it says 7 to 8 years old. I've also seen 8 or 9 years old. But suffice it to say, your optic pathway gliomas are 6 years and younger. We're following optic pathway gliomas with MRI scans, and then we find this brainstem glioma in the 6 to 10-year-old pediatric patient. Looking at where the brainstem is, we had a cartoon earlier looking at optic pathway gliomas. Let's look here at The brainstem has three main parts. There is the midbrain, which is in this turquoise light blue, the pons, which is in pink, and the medulla, which is in purple down here. The symptoms associated with brainstem gliomas, often, most commonly, there are no symptoms. These are found incidentally. However, they can be associated with a backup of or a blockage of the normal flow of spinal fluid through the brain. So the spinal fluid kind of flows around open areas called ventricles within the brain, and it bathes the brain. It flows all the way down, and it's like a one-way river that just goes around and round, like a lazy river at a resort. It goes round and round, and it goes by the brainstem, down the spine, back up, round and round. When you have a mass or a tumor that's in this area, there is a small little thin section of that lazy river, which can be blocked, and that can lead to backup of fluid up into the brain called hydrocephalus, or fluid collecting in the brain, and that can lead to headaches and nausea and vomiting. Other possible symptoms, if you don't have that blockage of fluid, then the brainstem itself can be associated with what's called cranial nerve palsies. These are nerves that control facial movements. So it could be an eye movement difficulty. It could be a smile difficulty, speech difficulty because of tongue movements, things like that. And there can also sometimes be some balance difficulties. Brainstem gliomas. Treatment is not always needed. And I think there are two studies, they're a little older, but they speak to the fact that there were 7 patients in Dr. Bronner's study where they had diffuse involvement, so not patchy involvement. This example over here is kind of a patchy involvement. 4 of the patients had symptoms and 4 were followed without treatment. All were alive and neurologically stable over 3 years later. And I think the most important thing to point out here is, again, for those who are trying to educate themselves and really understand for themselves and their families and their children, what do these tumors mean? There's a very big distinction between brainstem tumors in non-NF patients and brainstem tumors in NF patients. Because if you look up brainstem tumors or pontine tumors in non-NF patients, carries a very dismal prognosis, very rapid decline and deterioration. Whereas these that are in the brainstem tumor of neurofibromatosis patients, even with diffuse involvement, they seem to carry this very slow pathway without really progressing and without having any sort of neurologic decline, even without treatment. A second study Dr. Pollock did looked at 21 patients, again, focusing on diffuse involvement because of how important that is in the non-NF population. And 12 patients of these 21, so about 50, 60%, had symptoms. 9 were without symptoms. They were followed again for over 3 years. 10 showed some progression, but of those, 7 actually regressed and then stabilized without intervention. So I think it goes to show that we still don't know everything there is to know about neurofibromatosis. Some things get worse and then they get better. And so we're really trying to focus on, is this causing a problem in this patient? And if it is, then let's think about intervening and having a treatment. I think it's of note that 4 patients actually received treatment, usually for focally enhancing tumors, similar to what you see in the picture on the right, and those were also stable after treatment. So we do treat for rapidly growing or clinically worsening symptoms. So if there was a facial nerve palsy, some asymmetry in your movement, or headaches or hydrocephalus or any other finding, we would absolutely want to intervene and give medical treatment. Carboplatin vincristine is the same treatment as for optic pathway gliomas. That's because it's the same mechanism of what's going on in the brain with these tumors and their formation. So we use the same treatment. There have been 2 phase 2 studies. Right now there's a phase 3 study open for patients that have this particular type, the one I just mentioned. But that phase 3 study is based on these phase 2 results, where we treated 18 patients in one study and 50 patients in another study, of which a select group had neurofibromatosis. And there were nice responses in both of these studies. Again, it's not a home run, it's not 100%, but similar to plexiform neurofibromas, 70% of the selumetinib study showed a partial response to treatment. This is an example of what the treatment and treatment response might look like. So we have here, this is actually just outside the brainstem, but then involvement in the brainstem as well on the picture on the left, which follow the arrow across the picture on the right. The brightness or the contrast enhancement has improved after treatment. All right, briefly on high-grade gliomas. High-grade gliomas are a finding of adults, okay? It is very important to note that this has not been connected to a progression of optic pathway gliomas or brainstem gliomas. So it hasn't been that these brainstem gliomas turned into something very aggressive and malignant. This is very uncommon and actually occurs in less than 1% of all NF patients. The problem is when it occurs, we're having some echo. There we go. When it occurs, it is considered a malignant diagnosis, and similar to other adults with high-grade gliomas, there is not a curative treatment that we have at this time. Of note, for patients with neurofibromatosis, they normally have this, similar to the sarcoma timeline that was mentioned in an earlier talk today, at a younger point in their adulthood, so maybe 20 to 50 years old, versus most adults, we think of high-grade gliomas occurring 50 to 70 years old. So it occurs earlier in an overall lifetime, but still in the adult timeframe. And the prognosis is very similar to other people with high-grade gliomas, with a very short survival after diagnosis. Spinal tumors, these are just as rare. 1% of the population of neurofibromatosis actually develops spinal tumors, and similar to the high-grade gliomas, they develop in adulthood, not in the pediatric population. So this is not something I see routinely. What I have seen, and this also was spoken about with earlier tumors in the sarcoma and MPNST talk, is that you can have extension of plexiform neurofibromas into the spinal cord area that then compresses. And so it's not really a spinal cord tumor, but it affects the spinal cord. And so I'm putting it in my talk today. Usually they present with extensive debilitation, meaning that the spinal cord is involved with movement of the hands, the arms, the legs, and the sensation to those areas as well. And so if you have pressure on the spinal cord, you kind of lose some sort of functionality. And when you have that functional loss, then an MRI is usually ordered. Because there's usually compression, such as this picture here on the right of a plexiform neurofibroma that actually grew through a little back door to the spinal cord compartment through the neuroforamina, and then it kind of just formed this dumbbell tumor here and pressed against the spinal cord. This dark gray is your spinal cord, and you can see that it is completely pinched and pressed to the side, and then past the expansile mass, it opens back up. So the first step in this is, because there is compression, is to relieve the compression and see if you can regain your function. So surgeons are called in pretty early in this, as opposed to some of the brain tumors where we don't do surgery as first step for the most part. So again, this is that spinal cord plexiform neurofibroma that's grown in and is pressing against the spinal cord. In this particular patient, our neurosurgeons at Dell Children's went and removed the tumor. Although we couldn't, with our approach, we couldn't get to this most distant part of the plexiform growing through that neuroforamina, but you can see the spinal cord has re-expanded back out, and this is just some surgical changes here. Unfortunately, things that we always have to worry about with plexiform neurofibromas, we had our tumor, we had surgical removal with a re-expansion of the spinal cord, and then we had regrowth of this tumor and pressure back to the spinal cord here, where it's being pinched back to the side. And this was a conversion to MPNST in this tumor and in this patient. So just a brief overview now of the brain tumors that we've talked about. Young children, less than 5-year-olds, we're thinking of optic pathway gliomas, and we're getting our annual exams and our ophthalmology evaluations. Mid-childhood, we're thinking low-grade gliomas, typically in the brainstem. Early adulthood, you're going to have the increased incidence of the high-grade gliomas. The treatment we've gone over quite a bit, but what we did not talk about are the alternatives to chemotherapy. It's because we don't usually use them in brain tumors. A complete resection is a great tool and has an overall survival of 90% at 10 years. Unfortunately, if you're talking the optic pathway or the brainstem, these are not locations that you can surgically remove tumors because of their impact on other function. So it's very rare that we can actually do this particular type of intervention. Radiation is an effective therapy for many people, but generally speaking, it's too risky for the very young patient with neurofibromatosis. It comes with side effects, including the need for central line anesthesia, headaches, things like that when you're talking about irradiating the brain, and late effects, which are the big problems with neurofibromatosis, is we increase the risk of second malignancies. There's also already a risk of vasculopathies that Dr. Moodley presented with moya, and this can be increased after radiation in the brain. And you can have neurocognitive decline after radiation to the brain, especially in the young developing brain of the child. So because of these reasons, we usually don't use radiation. Thus, why my talk has talked primarily on chemotherapy. As we mentioned, there are research trials going on trying to see if we can do better than what we consider our historical control. And we do have some alternative drugs in our back pocket if those two don't work, or if for some reason there's allergies or other complications that you can't tolerate those drugs. Outcomes, low-grade gliomas are usually lumped together as an entire entity. So it includes the optic pathway gliomas and the brainstem gliomas. But of the low-grade gliomas, about 67% of them are optic pathway, 15% of them are brainstem, and the other CNS tumors are 10 to 15%. As we mentioned, the event-free survival is 60 to 70%, but overall survival is out to 90 to 100%. If we're in this other category, where we're a little outside those very sensitive structures in the brain, then resection may be possible, which has a great overall survival as well. And then the high-grade gliomas and the spinal tumors, again, I barely touched on in the adult population, but very rare and quite debilitating and malignant. And with that, I'd like to close and open the floor up to questions that came up both for Dr. Moodley's talk and
Thank you. Thank you, Dr. Harrod. That was excellent information as well. Let me see if we have any additional questions that have come up since you've been speaking. That was such a good overview. I don't think we have any additional questions. Let me check the chat really quick. Okay, the children's session just paused a little bit so that we could catch up and get over there. So if anybody has any unanswered questions, you can maybe ask them in the children's section.
And I have a question, I guess just a really quick one. So when you're going with brainstem tumors, is it safe to say that when you're if you're diagnosed with a brainstem lesion or tumor of some sort, it's not quite as, I don't want to say it's not quite as scary, it's still scary, but it's not quite the same as if you didn't have NF, you find you have something on your brainstem, they seem to,
yes,
for lack of a better way to say, behave better.
Yeah, so brainstem tumors, that's where I think it's very important. I love how my families and patients want to learn and understand disease, but understand that neurofibromatosis in the brainstem can be quite indolent, is found incidentally the great majority of the time. Brainstem tumors in the non-NF population is almost a death sentence within a year of diagnosis. So it's extremely aggressive and not the same disease on any level.
And if I understood one of your slides in your presentation, it sounded like even some of the people that have symptoms and have progression, it regresses, I guess. For some people, it gets better.
On the brainstem?
Yeah.
So some of the studies from the late 90s showed that. There aren't a lot of newer studies. I think one of the One of the interesting things that I think will come out of the current phase 3 study is it includes optic pathway gliomas and it's only the NF population, but optic pathway gliomas and tumors of neurofibromatosis patients, and we'll be able to watch that in a more modern setting, following with MRIs and selumetinib versus historical treatments of whether they regress. Now, all of those patients are being treated; none of them are just being followed. But the studies from previous institutions in small groups, 20 patients or less, showed that there was reason and instances where you would just follow with MRI scans and not necessarily, increase toxicity and bring in toxic drugs to someone who is clinically doing very, very well, because these tumors might, one, sit there and do nothing, or two, even one study showed some regression in some of them.
I bring it up because that did happen with my son. When he's much older now, but when he was 3, he actually had symptoms. He was throwing up and gagging, and he had something on his brainstem. It had grown to cover the whole thing, but we waited, and his symptoms slowly went away. And then,
It's gotta be nerve-wracking.
It showed like he grew and it didn't. So, but I know that's not always the case. I think there are a couple comments in the chat, Carrie.
Yes. After, is there an age that the patient reaches that there's less of a chance for the optic glioma to appear, or that they're kind of out of the woods, so to speak?
Definitely. That one case where I mentioned over 10 years old being associated with vision loss, that's so extraordinarily rare that we don't actually test for or do MRIs for optic pathway gliomas, usually after 10 to 12 years old. If we had one that we were following, we might continue to follow, but you would not do a screening without a really strong visual loss or concern on that front for optic pathway gliomas. And even ones that we have either treated and or never treated and just followed, we usually stop screening and stop doing MRIs somewhere in the early adolescence, 10, 12, 14, kind of depends on each patient and what our concerns are and their ability to cooperate with ophthalmologic exams and things like that. But yes, we do stop because we don't worry about it going into the teenage years.
Okay, good.
I think the other question here is adult pilocytic astrocytomas. We can probably hold that one since we're going into the adult kind of session, if that's all right.
Yeah, please, because I don't treat it.
It's a good segue.
I'm sorry, Stephen, but
it's a good segue to our next
So hopefully everybody saw that we shared that link, and then Dr. Harrod, can we share your slides?
Yes, I texted Carrie a while ago. Yes,
okay, we'll I think we'll email and we'll put them on the website and we'll email that to people. But anyways, so I think in the children's session, they're waiting for anybody who wants to come over there and talk about children's issues, about learning and other, whatever else is kind of left. I think there's still quite a few left. I don't know if Dr. Harrod wants to go over there and help out too, if she wants to jump in there.
I might have to, I've been on and off. I might have to jump away and come back.
Thank you so much, Dr. Harrod. We really
quite enjoyable.
You. It was,
thank you for organizing
wonderful.
it. The morning sessions were wonderful, and I'm happy to be invited.
Thank you.